Hello, I'm Carolyn Jones with Washington State Children's Administration, and welcome to another workshop on the web. Today we're happy to be bringing to you a workshop on behavior management with a focus on the needs of children between the ages of 12 and 18. Our workshop presenter today is Wendy Warman, who is a member of the Academy of Certified Social Workers and a 26-year veteran of child welfare. She is adjunct faculty with Pierce College and is director of the Washington Association of Treatment Foster Homes. Before we start our presentation today, we want to take an opportunity to say thank you for opening your hearts and homes to the children of our nation. We, social workers and program managers, would never be able to do the work we do without your help. You are a pivotal member of the child welfare team, and we want to tell you that we are very, very happy to have you in our ranks. Enjoy the workshop, and let us hear from you. Thank you.
So the first thing we're going to talk about is what I call patterns of misbehavior, or the pyramid of behavior, if you will, in terms of kind of starting out with what I call annoying misbehavior. I think this is kind of what all teens do, you know, which is the whining, teasing, nagging, pouting, and small tantrums. These are the things that drive every parent, child care staff, kind of wacko, but nothing that you really have to intervene on, if you will. These are the behaviors that we say is the best thing to do is ignore, 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 and hopefully they grow out of it, or they find a partner that can put up with it. The second one starts to get a little more difficult to deal with, and that's the disobedient behaviors, which are not following rules, not doing chores, nothing defiant, but just that kind of, I'm not going to do it, you can't make me sort of behavior. We start to get more into the defiant behavior, which is the refusing to listen or arguing. None of the kids that you work with ever do that, right? So this is where you really starts to push your buttons, that you really want them to do something or to shift their behaviors, and they start arguing with you, or they leave, they just won't even listen to you, tune you out, put their headphones on. The aggressive behavior is where we start dealing with more of the difficulty, more of the active defiance around verbally assaulting you, name-calling, put-downs, sometimes physical aggression, pushing, shoving, and then the all-loving biting, kicking, hitting, spitting, or fighting. So this is the behaviors that are the ones that are extremely difficult to deal with in a family setting. We're going to talk some about those, but this is not a class on dealing with physically aggressive youth. So just want to make sure that everybody knows that's a kind of a whole different class. So we won't be focusing as much on those. We're going to focus more on the disobedient, defiant, the behaviors that just drive us wacky in working with these kids and trying to help redirect them and give them some skills. So why are they angry? What's the payoff of anger? Why be angry? Any ideas? Vent. To vent, okay. Yeah, anger reduces the stress. These kids that we work with have lots of stress, have lots of emotional discord, and anger reduces that. Have you ever worked with a kid that after they are yelling at you, kicking something, hitting, then they're calm? And that's when you can really talk with them. That's when, because there's actually a physiological thing that happens with them. And the greater the stress, the number of stressors, the more unpleasant the arousal. So kids who have got a lot of emotional issues, a lot of stress in their life, the anger discharges the arousal, but only temporarily, as the stress comes back even stronger and is harder to control. So even though it's a temporary fix, it doesn't take care of the long-term problem. Anger also hides emotional pain. It's a good defense against fear, loss, guilt, shame, and feelings of rejection. It's the, I'm going to reject you before you reject me. I'm going to keep you at bay. And one of the ways to keep you at bay is to tick you off all the time and to keep pushing at you and to be angry. It keeps you from getting closer to a kid because it's harder to connect with them if they're always yelling at you, if they're always fighting with you. So it's harder to get in there to become, have an interconnection if they're always angry at you. And what they really want is that connection, but they can't, because of loss and all sorts of different issues. So anger hides that emotional pain, it's a good defense. The third one, of course, is anger gets attention. We talk a lot about this with foster parents and with child care staff when I'm working with child care in daycare and different places, is that for the most part, anger gets you notice anger and you respond to a kid who's angry, being disruptive. Very rarely do people go up and say, wow, you're doing such a great job of sitting quietly and reading. I thank you very much. They don't do that. But when the kid's bouncing off the wall, it's stop, so that kid gets a lot of attention. If there's one thing that you pick up from today is that you'll see in some of the techniques, over and over we talk about rewarding positive behaviors and increasing self-esteem. And that's a piece that I think we all miss out on with kids, is that it's because the payoff is you get more attention with anger than you do with good behavior. And trying to remember that is very difficult. So we'll talk more about that as the day goes on. Anger may be used for punishment or revenge. Some children use anger when someone has let them down. I'll show you. They may want the person to feel as much pain as they do. Unfortunately, when a child acts on this impulse, they can make enemies, and the punishment is full circle. So, a lot of times, you may be the recipient of the anger that a kid has to other parents, to other family members. And that makes it even harder, because you're like, well, what'd I do? I just gave you pancakes this morning, and now you're just blowing up at me. So it may be revenge or issues towards you, or it may be for some of the kids we work with, issues that they're dealing with their own families of origin. And then the next one is anger changes people's behavior. It's used to extort things from others. Once coerced with the blow-up or the fear of blow-up into complying with the demands of the child. This works for a lot of kids. If you are afraid that that kid is going to get angry if you ask them to do a chore, and you're not up for the battle, if you will, what's the best way to deal with it? Give it up. Yeah, don't ask them to do the chore. So many kids have trained us, if you will, to get out of things, to not have to be at a certain level, or to not do their homework, or to whatever the action is, because we're afraid of their anger. It's understandable, but that helps to change the behavior. Any comments, questions? This one you can get on the web. Okay, yeah, what I did was, I have so much in this classroom that what I made copies of is like the techniques and those pieces, but you can get You can get some of this, no, actually at the Pierce College website. Yeah. So when you go to the Pierce College website, you'll see this and some other things that I didn't print out for you. So anything that I don't give you a copy of will be on the web for you. Okay, so when does anger become a problem? Now, some of this is similar to what we've just talked about, and I know it's small. It says, anger can turn into bigger problems when the child is in a cycle, trapped in a cycle, or has dug himself into a hole too deep to get out of. During prolonged and frequent episodes of anger, certain divisions of the nervous system become highly activated. This is what I was talking about when there's actual physiological changes that happen with kids around anger. The blood pressure, heart rate increases, it stays elevated for long periods of time, and the stress on the body may produce different health problems such as hypertension, heart disease, diminished immune system, and so from a health standpoint, avoiding physical illness is motivation for controlling anger. So this is for all of us. And then another compelling reason to control anger is the negative consequences that can result from expressing anger inappropriately. So our kids that we work with many have anger problems. Many of them are dealing actually with health issues, both in terms of their, development, possibly poor nutrition, medical care, and then just as they're getting older, they're starting to deal with some of these health issues. Teenagers are beginning to see more and more, we're seeing more and more teenagers that have things like hypertension and health-related issues. And we've already talked about the payoffs. But as we said already, the initial payoff leads to negative consequences. For this reason, they are called apparent payoffs. So you might see that sometimes in a clinical report or something, the word apparent payoff, because the long-term negative consequences far outweigh the short-term gains. So the good, as I've said before, there's a short-term payoff for this anger. The long-term payoff is not very good. It says, for example, consider a father who persuades his children to comply with his demands by using angry tones of voice and threatening gestures. These behaviors imply to the children that they will receive physical harm if they are not obedient. They immediately pay off for the father, and the children obey, but the long-term consequences is that children may fear or dislike him or become emotionally detached from him. So you can put a kid's name in there, and that happens to a lot of the children we work with, is that they become disconnected from the people who they want to love, they want care from, but they're fearful of it, so they use that anger to keep you at bay. So, anybody worked with a kid that you knew wanted your love, but kept you, wanted that emotional connection, but kept you away through their anger? You were nodding.
A lot of our kids are like that.
Yeah. Oh, sorry. So, how did you deal with it on a day-to-day basis with that kind of kid?
I just kind of let him be angry. Let him know it's all right to be angry, and when he's ready to talk, we can talk. But I just kind of, to a certain degree, ignore it.
Uh-huh. Okay. Any other comments? Yes, sir. Oh, yes, right. I'm got to get used to that.
I remember one youth that I had, one boy that parents were separated. Mama's boyfriend was drinking and drugging and beating on the kids, stuff like this years ago. And this kid would act up. He'd beat up on other kids. He'd take out his anger on other kids. I had to separate him. And he had the problem, he just didn't think anybody really cared for him. And I basically pulled him off and said, look, I care about you, but I can't let you hurt the other one.
Absolutely.
And because I care about you and I know you can do better, I expect better out of you. That's why I have to stop you from doing this. And I made it clear to him that it was because I cared enough about him that I was willing to put myself in that position and take the time to work with him, that I was doing it, and I expected better out of him. I knew he could do it. When I put the positive input in that he could do better, that's when he took off and started to advance. Mm-hmm. So, yeah.
Yeah, so you've seen the results of hanging in there with a kid, of kind of getting through some of that anger.
Yep.
Yeah, we had a kid at the CRC that I worked in that every day I got to work about 10 to 9. The kids had to go up to the school. This was at the Y at 9 o'clock. And I could tell you that 5 minutes to 9 every day, this kid started acting up. So that, and the child care staff were all getting the kids, packaged up to get up to the classroom, which was up on the 7th floor. And every day this kid would start blowing up. And, because he just, the child care staff was, and it was, and he got closer. He literally got closer to my office door, to do his magic. And so finally I said, Reuben, do you realize that we do this every day? And could we come up with a new method for you and I to hang out together? And I mean, he was 15, 16 years old, and so we actually put something together where, he was rewarded by not doing that, by spending time with me in the afternoon. But it took me a while to figure out that what he was doing was wanting time with me. He didn't give a rip about school, whether going or not going. What he wanted was me. So we had to come up with a way to work that out. So any other comments about anger, about the payoff? Okay, so we're going to get clinical for a while. The first thing we're going to start with is oppositional defiant disorder, ODD. A couple of things. One of the reasons why I like to go over this is that you will see a lot of these issues, a lot of this verbiage in case records when you read them. If any of your kids are seeing a therapist, if they're at a community mental health agency. So part of the reason we do this is to make sure that you kind of get an overview of what are some of the common disorders that our kids get labeled. But the other part of it is there are some really good strategies in here in terms of dealing with these behaviors. So ODD, oppositional defiant disorder, is an ongoing pattern of uncooperative, defiant, and hostile behavior towards authority figures. And it seriously interferes with the youngster's day-to-day functioning. It generally begins middle grade school years and has developed by early adolescence. None of the kids you work with, I'm sure, have this. I'm teasing. A lot of kids that you will see in younger kids in particular will have a diagnosis of oppositional defiant disorder. It says, where all children are oppositional from time to time, particularly when they are hungry, tired, or upset. A kid with ODD, it becomes a concern given the frequency and the consistency that stands out when compared with other children that you work with or you see. And they are often identified fairly early. Oppositional defiant disorder kids, you can see pretty early on in your work with them. This is kind of the precursor, if you will, to some other disorders that I actually have for you. The behavioral features. They have to display it for at least 6 months. So most diagnoses we look at over a period of time because every person goes through a time in their life when they might be more stressed or upset or situations. So we want to see, is there a long, chronic period of time that this kid is showing these behaviors. And then the other part of it is that it's usually seen in multiple settings. So in the home, in daycare, in the school. We do see kids that do, for example, better at home than they do at school. Some kids where daycare is more of a struggle. And when we talk about kind of some treatment recommendations, you'll see some reasons why kids do better in some places than others. So, frequent symptoms. These are the things that you guys see and deal with all the time. Frequent temper tantruming, excessive arguing with adults, active defiance and refusal to comply with adults' requests. I'm not doing it, you can't make me, and there's nothing you can do about it. Ever hear that? Always. Deliberate attempts to annoy or upset people. The ones that you know that they're doing it just to get you. You know? Blaming others for his or her mistakes. Not me, I didn't do it. She did it. Often being touchy or easily annoyed. Frequent anger, resentment, mean, hateful, and seeking revenge. The causes are unknown. But many parents report their children with ODD were more rigid and demanding from than their child's sibling from an early age. We found that kids with oppositional defiant disorder very early, you know, don't like to be touched or more uptight, less calm. So, you know, if it was a kid that you had raised from birth, you might have seen these differences fairly early on. Okay, I should give you this one. Okay, thank you. Okay, so treatment recommendations. Children who exhibit these behaviors should receive a comprehensive evaluation that includes input from 4 primary areas. So this is where you actually get the appointment for an evaluation at the mental health center, and you want, they interview the child, they interview the parent, they often have documentation for a teacher to do, including a behavioral checklist, and then direct observation. And that will be used to put together this diagnosis. Many kids with oppositional defiant disorder also have attention deficit hyperactivity disorder. Not all kids, but they have found there's a correlation between the two. And I think that they're going to find, my guess is that they're going to find that because they're finding the physiological reasons again around ADHD, I think they're going to find also there's a physiological connection with oppositional defiant disorder. So, okay, treatment includes parent training programs to help parents manage the child's behavior. So what you hear there is that that's something for the parent to manage the child's behavior. It's not a magic pill that they can give the kid. Sometimes individual psychotherapy, more effective anger management tools. Individual therapy with teenagers, psychotherapy in the classical sense doesn't work as well, so they're using more kind of group anger management kinds of techniques with kids. Psychotherapy for families to improve communication, and cognitive behavioral therapy to assist problem solving and decrease negativity, social skills training. This one is, again, a lot of groups are now moving towards social skills training. Helping a kid, if this happens, then this happens. If this, then that, you know, how can you get your payoffs other than with anger? Let's see. You'll see right here, medication is useful in cases where the child presents with symptoms in addition to those associated with oppositional defiant disorders such as ADHD. That means there's no magic pill to help a kid who is oppositional defiant. Unless we're talking about a kid, which we'll talk about in a minute, who's depressed or some of those kinds of things. But oppositional defiant disorder really has to deal with what we call environmental management. And that means building on positives, which we've talked about already, taking a timeout break if you're about to make the conflict with your child worse, not better. When my son was about 4 or 5 years old, one time he and I were just locked into a battle, and I knew that I was not doing what I needed to do when he said to me, "Mommy, we need to take a time out, both of us. You go to your room, I go to my room." And I went, oops, because he knew that we were locked into a battle that neither one of us was going to win. And so, taking that break, guess what? You're not going to win every battle with your kids. It's okay. There'll be plenty more of them. I promise. So, so taking a time out, and then number 3 talks exactly what I said. Pick your battles. There are certain battles that you are not going to win. And with an oppositional kid, they thrive on those battles. You're exhausted. They're energized. Yeah, let's do it again. So make sure you pick your battles. What is it worth to you? On that. My son, I call them Philip droppings, where he comes home and, his backpack is here, his shoes are here, his socks are here, his shirt is here, his pants are here, his Game Boy is here. I mean, it's like a trail, like Hansel and Gretel. I figure, his roommate in college is going to have to deal with it, because I could never get him to change. And so that's why we call them Philip droppings, and every once in a while I'll yell, "Pick up your droppings," but he generally doesn't. So his father does it. So number 4, set up reasonable age-appropriate limits with consequences that can be enforced consistently. As much as you can, look at that kid and think, what is reasonable for his age, her age, and what can I, as consistently as possible, what can I set up and what can I enforce? Don't set up some magical system that you're not going to be able to reinforce and enforce. Maintain interests other than your child. So this is a little self-care that you'll see in all of these, which is make sure that you get support for yourself, that you take respite, that you have outside activities, because living with a kid who's got ODD can be really tough. And then you see on here, there's positive reinforcement, timeout, response cost, and then token economy. These are some discipline techniques that you can use. Unfortunately, some children who move from oppositional defiant disorder move into what we call conduct disorder. Have you ever heard this verbiage in a report, seeing this kid is, diagnosed with conduct disorder? So this is generally I would say mostly for adolescents. Very seldom do you see a diagnosis of conduct disorder with a little kid. They're usually diagnosed as oppositional defiant. But as they get older, they get the new label, which is conduct disorder. And this is a kid who has great difficulty following rules and behaving in socially acceptable ways. So that's one of the words catches right there, is the socially acceptable ways. Other children, adults, and social agencies often view them as bad or delinquent rather than mentally ill. It's defined as repetitive and persistent patterns of behavior in children and adolescents in which the rights of others or basic social rules are violated. So this is the kid that you say, has no conscience, doesn't care what about society, will lie, cheat, steal, for what they think is their better good for themselves. The second paragraph talks about many of them have trouble feeling remorse expressing sympathy, and reading social cues. They often misinterpret, happens a lot for foster parents, they misinterpret the actions of others as being hostile or aggressive and respond by escalating the situation into conflict. So have you ever worked with a kid that you think, you've just had an interaction, not necessarily positive or negative, but something, and they just react kind of totally off the wall. They get so angry with you, or they get so hostile, and you're like, where'd that come from? I thought we were just talking about, picking up their plate after breakfast. And these are kids that they misinterpret the cues. They see the actions, and they're very difficult to live with. Kids with conduct disorder are very difficult to live with. Oppositional and defiant, you just go on a go. But conduct disorder kids are very difficult because you just can't, they're much more volatile, and you can't, the trust issues. These are the kids that, as a social worker, I tell you to lock up your purse and put a lock on your bedroom and lock the alcohol cabinet, and because that's just that has been their survival. I want to preface this that I'm not saying anything about a kid being bad or wrong. These are kids that have come from very difficult lives. The behaviors, the mental health issues that we're talking about here, come from very sad, poor upbringing, drug infected, all these different kinds of issues that our kids come to. But they come into your home and they bring these behaviors, unfortunately, and you're the ones that are working with them and trying to make a difference. So I'm certainly not trying to say they're bad kids. These are the behaviors and the mental health diagnoses that they come into your homes with. Okay. So, behavioral features. Aggression to people and animals. For some reason, a lot of kids with conduct disorder have difficulties with animals. It might be that one up, one down situation. In the group home I worked with, I, again, stupidly brought a puppy with me, because I got out of college, I want a puppy, and I took this, the kids will love this puppy, and she was a wonderful dog until I found one kid, anytime I turned around, he was whapping the head of this puppy, and guess what? He was diagnosed conduct disorder, but I didn't know that in terms of where I was at with my skill set. I would have never brought this dog with me because she was just a sweetie. So anyway, so a lot of kids are cruel to animals, to people. A lot of kids with conduct disorder have this issue around weapons, and I'm sure it's a defense mechanism for issues that have come on into their lives, but they get guns, they build, they have knives, they have bottles, so that makes it very difficult, for you to live with them. That's the hypervigilance that you have to do as a foster parent, as a child care staff, in dealing with these kinds of kids. Many of them are destructive of property. They don't get it. They don't see any connection that burning down your home will mean they don't have a home. So a lot of kids that I've worked with with conduct disorder have the issue around fire setting, which of course makes it very hard to find a foster home. The day-to-day problems turn into these kinds of issues. Substance abuse, risk-taking behavior, school problems, and physical injury from fights. So they begin to move into their behaviors bring them into other problems. A lot of kids who have conduct disorder will become users of drugs, so they're trying to self-medicate themselves because, it's not like they like to be this way. Causes. we're seeing a lot more connection to brain damage, fetal alcohol syndrome, child abuse, genetic vulnerability, traumatic life experiences, which is, of course, mostly what our kids have when they come into your homes. Research shows that youngsters with conduct disorder are likely to have ongoing problems if they and their families do not receive early and comprehensive treatment. These are kids that it's tough. You're gonna work with them. Hopefully, you're going to be able to provide them a loving environment, one with lots of controls and supports. But it's going to be tough. They're going to have a tough go of it in life as adults. And that's really hard, I think, for caring adults to see that. We want to fix them. And all we can do is help them and give them some tools. But I caution that, a kid with conduct disorder, it's going to be pretty tough for you to see them as the next CEO of a company. They may be very bright, they may be smart, but the vulnerabilities that get them to where they're at is going to make their lives pretty tough. We've already talked about this part. This is interesting. Many children with conduct disorder have coexisting conditions such as mood disorders, which we're going to talk a little bit about, anxiety, post-traumatic stress disorder, a lot of substance abuse, a lot of, in terms of teenagers, learning problems, or then also thought disorders, which is that early psychosis. And common models of intervention include therapy, group therapy, behavior therapy, social skills training. Some medications help, and then these are the kids that we see in residential treatment in programs like yours, and treatment foster care, and maybe even in your home. Let's talk about environment, because this is what's going to help you live with a kid. Keep the kid on a daily schedule. Rules, routines, what time they wake up, baths, leave for school. These are kids that are going to need that structure because they have no internal structure. Cut down on distractions. Loud music, computer games, television can be overstimulating, especially if they have attention deficit disorder. Make a rule to keep the TV or music off during meal times or while doing homework. Whenever possible, avoid taking the child to places that are too stimulating. Organize your house. Limit choices and find activities that these kids can succeed and use as calm discipline as possible, which is not easy. And I recognize that. Any comments, questions about conduct disorder? And finally, what I brought with me today is the mood disorders. Mood disorders are what we talk about: major depressive disorder, dysthymia, and bipolar. Population shows that any one time between 10 and 15% of children and adult population has some symptoms of depression. What we want to talk about is the 7 to 9 months, because everybody goes through a period of time when they're depressed. When life is not as good, or they've had a major serious loss in their lives. But this is a situation where it's a long, what we call chronic. This was interesting. Before puberty, major depressive disorder and dysthymia disorder were equal in boys and girls. And then after the age of 15, twice as common in girls and women as in boys and men. So some of that does have to do with hormones. So there's that old joke about, oh, it's that time of the month. Well, some of it's true around hormonal differences in our bodies and why some women, why the instances of depression are higher. Of course, the issue with mood disorder is that some kids, the risk of suicide, so we have to take this seriously. There was a time when we used to say, oh, it's just a threat, that she or he would never do it, but we want to take any suicide attempts or discussion about it seriously. The incidence of suicide attempts peak during mid-adolescence, and death from suicide steadily increases through the teens, and it's the third leading cause of death in that age. So the increase of suicide is a huge issue that we have to take seriously with the kids that we work with. Okay, so we're going to talk about the behavioral features of the main disorders. Major depressive disorder, that's a serious condition characterized by one or more major depressive episode. So that means that it lasts, an episode lasts longer than, on an average, 7 to 9 months, and then we're going to talk about the clinical features. So that means that an episode has been a longer period of time, 7 to 9 months. And they are sad, they lose interest in the activities that used to please them, they criticize themselves, they criticize and feel that others are criticizing them. So these are the kids that, one day they just stop horseback riding, or they stop their interest in piano, and then they and it's not just because it's dorky to play the piano or something. We're gonna, some of those teenage issues that we'll talk about in a minute. It's because that you see these other things that happen in addition to it. So not just one thing means it. They start talking hopeless. I don't know why I should bother to go to college. We're going to have a nuclear war, and the whole world's gonna be gone anyway. We're not going to get oil because the Middle East is going to blow up. Life is so horrible, I'm not going to bother. So they begin to talk about the future as if it's not worth living. Our kids in particular may say things like, well, my mother died of a drug overdose, and I'm probably going to do that too. So, why bother going to school? I mean, this is the things that you may hear. This one it's highlighted, and this is really important because we see this a lot with boys. A lot of boys who are showing aggressive behavior are actually depressed. And it's hard to differentiate that, but that's why sometimes you might have a kid in your home, and if you're working with a doc or a psychiatrist, and they put that kid on antidepressants, you're going, wait a minute, he doesn't seem depressed, he seems aggressive. What we know about some kids is that they're actually, the aggressive behavior is trying to kickstart them out of their depression. And so, particularly boys, we see this more with boys. So, take a look at that. If you have a kid in your home or in your program, and you're seeing a lot of irritability and aggressive behavior that is kind of uncharacteristic of that kid, you might want to have them assessed for depression. We have seen this with a number of kids and then the antidepressant medication decreases the aggressissive behavior because they're not oppositional, defiant, they're not contact, they're actually really depressed, and they're trying to kickstart themselves out of it. So check that with a lot of the, particularly boys that you work with. Then there's the issues around hygiene, appearance and then their sleep patterns become disturbed. Either a kid, it can work both ways. Kids who sleep all day, and don't want to do anything and go anyplace, and that's not just the normal teen, I'll sleep till noon over spring break. I mean, we're talking about kind of a chronicity of sleep patterns. Or they can't sleep. There's a change in their patterns, and you hear them walking the halls at night. So that is a major depressive disorder. Now, a lot of our kids, you'll probably see this. Have any of you seen the word dysthymia or dysthymic disorder in a case record? Nope. Okay. They may not use it as much as they used to. They used to diagnose dysthymic disorder more for teenagers because as it says, it's like a major depressive disorder, but it has fewer symptoms and it's more chronic. So it means that it lasts, it's been there a longer time, and it's and that it says, and the symptoms continue for years. Average duration of a dysthymic period in adolescence is 4 years. So these are kids that have been depressed for a long time, where a major depressive disorder usually has a spike, and it lasts, and then then they either they get through the issue that's caused some of the depression, or that it begins to move into that more persistent in nature. I like this. Sometimes children are depressed for so long they do not recognize their mood as out of the ordinary. So a lot of people, this is just the way they think their life is. So a lot of times when people are put on an antidepressant, because maybe a person that they live with say, I can't take your ongoing depression, you've been like this forever, and they come out of this fog and go, oh, okay, I didn't even know I was depressed. So so this has the same symptoms, but it's more chronic. Now, any question on those two? Yeah.
Do they have any attachment problem with the dystonic disorder? I've seen a girl who had, it won't be apparently visible that she has depression, but she won't attach to anybody. She has problems trusting people, either foster parent or the bio parent, and school teachers, peers, anybody.
Yeah, I don't know. I don't know of research that connects, chronic depression with attachment. But just out of thinking about it, particularly with the kids we work with, if they have issues around attachment and they have, chronic depression, I would see that they could go hand in hand in terms of, if I am afraid to connect with you, think of life without connections with people that to love and care and nurture you. I'd be depressed too. So I would think, my guess is there's some research that connects them, but I don't have that. But I would guess that. Any other questions? Mm-hmm.
In the dysphymia disorder, is it difficult to diagnose for that reason because the children may not have been in the system that long, or it's actually the child telling you, I've been feeling this way for 10 years, or...
Yeah, I think it is hard to diagnose for kids that we work with, and so I think you're going to see major depressive disorder a lot more as the diagnosis early on. Okay. But I think when we're putting kids on, and however you may feel about antidepressants, we're not going to get into that. But for some kids, it works really well, and though they have to figure out which one, those are the kids that come out and they go, wow, I really didn't know I was depressed, or wow, it's like I said, coming out of a fog, because we don't have the history with them. If it's a kid that you might have adopted early or was born to, you might be able to see that pattern and see those kinds of behaviors. So I think so. I think it is difficult to diagnose. A good child psychiatrist will look at a record and look at some of that and be able to say, I think this is a chronic systemic depression. But I'm not sure that there are very many child psychiatrists that have the time now to be able to do that in our current system. Okay, so the next one, oops, I pulled it off before we talked about it. Bipolar disorder. It's a little bit over here. Bipolar is also called manic depressive disorder. This has become the catch, the darling of, it's a diagnosis, is the darling of diagnosis when it's on the cover of Time magazine. So it's currently the darling diagnosis. A lot of kids are now suddenly bipolar. I don't know whether that's true or not, but that's just my editorial comment. So, mood disorder in which episodes of mania alternate with episodes of depression. Now, the problem with diagnosing teenagers is that's what a teenager does. Is that they're like jubilant and happy. Oh my God, I get to go, to this rock concert this weekend. Oh my God, my life is crap, because, Susie Cream Cheese didn't ask me to the prom or whatever. It's so, I think this one is overdiagnosed. One woman's opinion, but it's a huge issue that's coming out more and more.
You find it to be a broad diagnosis as well?
Yeah, it's a pretty broad diagnosis, but it's interesting. It's interesting to look at, and I'm not saying that there aren't bipolar teenagers. I have a friend who has one, and she has struggled, with medications and behavior management in schools, and knock on wood, he's going to graduate this June. But it's a very difficult It's a very difficult disorder to live with. First manic symptoms may not occur for months or even years thereafter, or may occur during the first depressive illness or later after a symptom-free period. I'm going to have to fix these. And so actually what they're finding is a lot of kids are getting diagnosed later, like 17, 18, 19, which is good. I'm glad to see that, because I think it's near to impossible to diagnose this in the early ages with, again, the kind of bouncing. So they feel energetic, confident, special. They have difficulty sleeping but do not tire. This is during the manic phase. They talk a great deal, speak rapidly or loudly. They may complain that their thoughts are racing. They may do homework quickly and creatively, but it's disorganized and chaotic. When manic, adolescents may have exaggerated or even delusional ideas about their capabilities and importance. They may become overconfident and may be fresh and uninhibited with others. So that's when they're in their manic phase. They start numerous projects. They don't get them finished. They may engage in reckless or risky behavior, what teenager doesn't. And then some say that there's sexual preoccupation or increased in that manic phase. So that's good. I think it's really good that we're doing so much research in depression, because it is a significant part of our society. Now, of course, that raises the question, were we always depressed, or, is it now, more depressed because of our society and all that? I have no idea, other than we know that kids that we work with have a high incidence of mood disorders, and that there are a lot of adults, for whatever reason, who are dealing with mood disorder issues. So, with treatment recommendations, the good news is that all three, major depressive disorder, dysthymic disorder, and bipolar, are responsive to medication interventions. And what we found that, kind of traditional therapy, it doesn't really work that well until their mood is stabilized. If you're feeling like your life is in the toilet, discussing, what happened when you were growing up isn't very helpful. You've got to get your mood stabilized. And those of you who have worked with kids and doctors around medication management, this statement is absolutely critical. No one medication works with all children, and there's a trial and error process. How many of you have dealt with that with a kid where, one medication just is great or it doesn't work and the doctor tries something else and they change it and you're thinking, God, can't they figure out what to do, with this kid? But they really are. It really is a trial and error because we can't see what's going on in their brain, so so the doctors are trying different medications because there are different reasons. So don't be discouraged if, don't give up. There are also nutritional elements to depression, and food, changing some of their diets, I think is really important to help kids who've had poor diets. And work with those doctors around medication management. Keep a log if you have to around what's going on with that kid if you've got them on medication. I think that's really helpful because then you're able to go back to the doctor and say, this is working, this is not working, this is what happened this week, this is what happened at school. A good evaluation. Hopefully you're able to get one. And then working with the school, of course. It says, it can also help improve the child's ability to function at home, school, and community if everybody's involved. It says the family, but I say, the whole community if the kid's involved in anything. I've worked with, Boy Scout leaders and campfire leaders and Girl Scouts and people who I'm able to say, this is a difficult kid, this is a good kid, but struggling, would you, take them into your basketball team or something like that. So helping the community to do that. We've talked a little bit about, this is I think I got these in wrong order. These are the risk factors for suicide, bipolar disorders, depression. You've got to deal with issues around the suicide that we talked about earlier. A comment here, it says the next most important risk factor is a previous suicide attempt, which increases the risk approximately threefold. So when a person has made a suicide attempt, the likelihood that they will be successful increases. So making sure that we work and supervise kids who are depressed, making sure that we try to make sure our environment keeps them safer. Okay, we've talked about suicide. Jesters need to be taken seriously. I already said this. Parents should take daily notes of their child's behavior, mood, sleep patterns. So we've talked about that. Try as much as possible to maintain open communication with the child. Structure opportunities for your child to talk about their feelings on a regular basis. Just don't assume that kid can talk to you. They may not be able to, whatever's going on. So you have to set up times. A flexible, low-stress house and school environment. Talk to the school. They can make accommodations for your kids. Say the word IEP, Individual Education Plan. Adherence to medication and treatment. This is tough. There's no getting around it. It's tough with adults. It's tough with teenagers. When they're feeling in the manic phase, they don't want to take the medication because guess what? That manic phase is fun, So I'd want to stay up all night and do creative and wonderful things. So don't give me that medication that's going to make me go to sleep and dull my senses. And some kids who are really bright who are bipolar can quote, famous people who are bipolar and say, if we didn't have this, then we wouldn't. Einstein was bipolar, whoever it was. And that's tough. So as much as possible, try to adhere to that treatment plan and medication. And early intervention can often stabilize mood and restore wellness. You can best manage relapses by prompt intervention at the first reoccurrence of symptoms. So if you have a good communication with your child, with the kids in your program, and you're trying, then if you early on, you might be able to say, do you see what's happening? You know, this is a cycle. We've gone through this before. Let's try to deal with this. And finally, okay, a symptomatic child should never be left unsupervised. We've talked about that. I like this. Parents, learn all you can about bipolar. Join support groups, networks with other parents. It's really, I think it's a really tough disease to live with. I mean, you're talking about your friends, you know, yeah, and daughter-in-law. It's very difficult, you know, because they're often folks with this often are very creative, exciting people, you know, but when they're either end, it's very tough. And we talked about special education staff and using parents, using the school team to help you with this. Okay, effective techniques. Practice in teaching their child relaxation techniques. I'm going to have some of those for you this afternoon. Prioritize battles, letting go of the less important matters. That one is critical. Reducing the stress at home, including learning and good listening skills and communication skills. Using music, light, sound, water. Some people are very responsive to, you know, those stress reduction techniques of water ponds and music and things. Find out, experiment, you know, see, it works. Become an advocate for stress reduction and accommodations in school. We've talked a little bit about this already, but, you know, kids they can make those accommodations. Some kids, the stress of 6 periods is too much. You know, is there something else they can do? Help the child anticipate and avoid or prepare for stressful situations by developing coping strategies beforehand. So when they're in that kind of calm period of time, this is where the communication comes in. Let's talk about what are the strategies you can use when you're up here, when you're down here, communicating with them, using signals, helping them to develop skills for that. And providing good structure, routine, and remove objects from the home or locking them in a safe place that could harm themselves or others during a rage, especially guns, medication, etc. Any questions? Oh, hold on.
Not necessarily. I have a mom who is bipolar, and how safe it is to return the child to her. That's my real struggle.
Yeah, I can't answer that. I think that, you know, that is a tough question in terms of child safety. You know, what I would look at, you know, how cognizant she is of her disease. Is she avoiding it? Is she involved in a community mental health center? You know, is she getting treatment? Those kinds of things. In particular, you know, when we look at return around child safety, I mean, there are people who parent children who are bipolar, you know, but they're quite aware of it. They have a support system set up. They have a mental health agency or a doctor that they're connected to. If she's in denial about it, then you've got a whole other issue.